Let's jump right into an operating room nightmare, where a seemingly routine procedure turns into an absolute fight for survival in a matter of seconds. Welcome to today's Explainer. We're diving deep into some truly fascinating and frankly high-stakes medical education, from a phenomenal masterclass module on surgical, critical care, and hepatobiliary emergencies by Dr. Omair Maksooth official. Today, we're focusing on one specific, terrifying clinical scenario that literally every surgical and medical team dreads. So picture this. You've got a surgical team performing a laparoscopic liver resection. They're navigating the anatomy, everything is going exactly to plan, and then, bam, a tiny tear in a cyst wall. It's just a minor spill of fluid into the peritoneal cavity, right? Well, within exactly 1 minute, the alarms start blaring. The patient develops profound bronchial spasm, their skin erupts in generalized urticaria, and their blood pressure just completely plummets into life-threatening refractory shock. The entire room goes from this calm, controlled routine to an absolute code red.
Which brings us to Section 1, Anaphylactic Time Bomb, the intraoperative nightmare.
Now, in that incredibly chaotic moment, junior trainees might suspect a bizarre reaction to anesthesia or maybe a sudden massive hemorrhage. But it's actually neither. What we're seeing is an explosive anaphylactic reaction triggered by something hiding deep within the liver. And this brings us to a massive clinical puzzle outlined in Dr. Omair Maksooth official series. What exactly turns a silent fluid-filled liver cyst into an immediate life-threatening emergency? Well, to figure that out, we really have to look closely at what is actually inside that fluid.
Let's get into Section 2, the parasitic culprit, a zoonotic invader.
Okay, so here's the wild part. We aren't dealing with a benign tumor or just a standard bacterial abscess here. The diagnosis is Hydatid cyst disease. This is a living, zoonotic parasitic infection caused by the larvae of the Echinococcus granulosus tapeworm. It's an invader that literally crosses the boundaries of species, often moving from sheep and dogs right over to humans through contaminated food or water. And once ingested, these larvae catch a ride through the portal venous system, migrate straight to the liver, and quietly build themselves a highly specialized biological fortress.
As described perfectly in the source material, a hydatid cyst is essentially like a pressurized biological cluster bomb. The outer wall of the cyst acts as the casing, keeping an unbelievable amount of internal pressure contained. But if there's a rupture, whether that's from a scalpel, blunt trauma, or even just spontaneous tearing, it releases thousands of pieces of parasitic shrapnel that instantly seed the body and trigger that immediate, terrifying shock response.
Moving on to Section 3, Anatomy of the Cyst, Deconstructing the Bomb.
To truly appreciate how to diffuse this threat, we have to peel back its microscopic defenses and look at its construction. The cyst is made up of 3 distinct layers. On the outside is the paracyst. Interestingly, this is actually host-derived fibrous tissue. It's the human body's desperate attempt to just wall off the invader. Then, moving inward, we find the ectocyst, which is the parasite's own acellular laminated shield. And finally, right at the core is the endocyst, or germinal layer. You can think of this inner layer as a biological factory. It is constantly pumping out hydatid fluid, daughter cysts, and thousands of tiny larvae heads known as hydatid sand.
Here is where it gets dangerous. If even a single drop of this highly immunogenic fluid escapes into the peritoneum, the patient's immune system instantly recognizes the alien proteins. This triggers that massive, overwhelming IgE-mediated histamine release we saw earlier. The blood vessels dilate, airways constrict, and within 60 seconds, the patient crashes into profound shock. It is a complete physiological avalanche.
Which leads us to Section 4, the water lily sign, detecting the threat.
Because the consequences of a fluid spill are so absolutely catastrophic, surgical teams just cannot go in blindly. When looking at an ultrasound or a CT scan, doctors are actively hunting for a pathognomonic marker known as the water lily sign. And while that might sound kind of beautiful, for a surgeon it is a terrifying visual. What you are actually looking at is the inner germinal membrane, that endocyst, having detached and collapsed, literally floating within the cyst fluid like a lily pad on a pond. Seeing this confirms exactly what kind of biological weapon you're dealing with.
Next up is Section 5, the PAIR protocol, step-by-step diffusal.
Once this cyst is identified, you absolutely cannot just cut it out like a normal cyst. Doing so is pretty much inviting disaster. Instead, professionals follow very strict World Health Organization guidelines. First, the patient takes an anti-parasitic drug called albendazole for 1 to 2 weeks. This helps chemically weaken the parasite and drop that internal pressure. Then they use the PAR technique. That's P for ultrasound-guided puncture, A for aspirating the dangerous fluid to decompress the cyst, I for injecting a scullicidal agent to actually kill the parasite, and you let that sit for 15 to 20 minutes. And finally, R for re-aspirating the neutralized fluid back out.
And that brings us to Section 6, Safe Surgical Inactivation, Protecting the Patient.
Now, sometimes the PAR protocol just isn't enough, and formal surgical removal is going to be required. When that happens, having perfect surgical hands isn't enough on its own. You need a chemical safety net. To prevent that 60-second crash into shock, surgeons meticulously pack the entire surgical field with sponges soaked in 20% hypertonic saline before they even touch the cyst. If a tear happens, this hypertonic solution causes immediate osmotic lysis. Basically, it instantly destroys the escaping protoscolices on contact, totally neutralizing the anaphylactic threat before it can even spread.
But here's a massive, critical warning highlighted in Dr. Umair Maqsood Official's module, and it's highly board relevant, by the way. When injecting scullicidal agents during surgery, you have to be incredibly careful. If there is any suspicion whatsoever that the cyst communicates with the patient's biliary tree, meaning the bile ducts, you must absolutely never use formalin or absolute alcohol. Yes, they will kill the parasite, but if they leak into the bile ducts, they will burn them, causing irreversible sclerosing cholangitis. That is a devastating lifelong liver complication. You have to stick to safe alternatives like the 20% hypertonic saline we just talked about.
The sheer complexity of managing this single pathogen is really staggering. It requires a perfect blend of pharmacology, radiology, and meticulous surgical precision. But taking a step back, it leaves us with a much larger, provocative question. As human populations expand and zoonotic diseases cross animal boundaries way more frequently, how many more of these biological time bombs are just hiding in plain sight? It truly makes you wonder how deeply our environmental interactions are going to dictate the high-stakes surgical emergencies of tomorrow. Thank you so much for joining this explainer, and keep your curiosity sharp.